Hello, I'm Dr. Mas Chaponda, consultant physician at the Royal Liverpool Hospital. Today I'm going to cover an important aspect of infectious diseases for the MRCPCH1. And this is malaria. It's common in the exams. The reason it's common is that we don't usually get trained on it, and yet it's a very important aspect of travel medicine. It's the commonest cause of death worldwide, and it's the commonest cause of admissions due to infectious diseases in the UK. So the aspects for the exams, which are also aspects of management for malaria, I will cover here. Firstly, if you see a question where the patient has traveled to either to Africa or Southeast Asia, then regardless of the presentation of that patient, your number one diagnosis and differential should be malaria. This is strengthened if the patient has fever and anemia. I would say always malaria. Always malaria is the diagnosis. Malaria can also present, especially falciparum malaria, with low platelets and raised bilirubin. This is a function of the spleen. Essentially, the red cells, which are parasitized, are going through the spleen, being cleared off and breaking up. Hence, you have the raised bilirubin from hemolysis and the low platelets, which are also captured by the spleen. In addition, and this is a rare presentation of malaria, you can have a hyponatremia and evolving renal failure. And again, this can happen with falciparum malaria or with malaria itself. In terms of diagnosis for the exams and actually in practice, thick and thin films are still standard. And here on the right, you'll see a caption showing a thin film. And if you look closely, you will see what look like headphones inside red blood cells. And that is falciparum malaria, which will look like that. There is also an antigen test that you can do. And again, that will tell you positive or negative whether the patient has been exposed to falciparum malaria. Now let's look at the treatment of malaria. The preferred choice for the exams and in clinical practice is IV quinine. And you'll see the caption there from quinine, which has been used from the 50s. It is still our preferred management of choice. And this has to be given by intravenous use ideally. There are newer drugs, especially from China, which are the artemisinin. So artemether-lumefantrine can be given orally for moderately to mild malaria. Chloroquine and primaquine can still be used. There is widespread resistance, and therefore for the last 10 years we have discouraged the use of chloroquine and primaquine, except for the benign malarias and except for areas which have not used chloroquine and primaquine for a long time and therefore have lost that resistance. It still has a role, hence the question mark after it. Fansidar, which is sulfadoxine-pyrimethamine, is no longer recommended. In the exams, this is a wrong answer. There is widespread use of SP, or Fansidar, and therefore widespread resistance of malaria to this drug. So let's look at other aspects of malaria which build around the diagnosis and the treatment. So which of the following are true regarding the treatment of severe malaria? Loading dose of IV quinine is contraindicated in one who is taking mefloquine prophylaxis. Initial IV quinine should be started, then oral doses should be given. Monitoring of blood glucose should be done on those on IV quinine treatment. In a comatose patient, without raised intracranial pressure, lumbar puncture should still be avoided because of the risk of cerebral edema in cerebral malaria. And finally, exchange blood transfusion is contraindicated because of the risk of renal failure. So which of those following statements are true? The first three are. So what we would say is loading of intravenous quinine is contraindicated if you have mefloquine on board because there's the risk there of getting QT prolongation from the two drugs interacting. IV quinine should be started, then oral, because you want to load up, and to load the dose to get to the plateau phase, ideally the quickest way to achieve that is through IV loading. Monitoring of blood glucose should be done for two reasons in malaria. One, the parasite itself causes hypoglycemia, but secondly, IV quinine in itself can cause hypoglycemia. So two reasons for monitoring blood glucose in malaria. Comatose patients, regardless of the raised intracranial pressure, if you are considering an alternative diagnosis such as meningitis, then a lumbar puncture should be done. Exchanged blood transfusion has got very little evidence-based data on it, but it's not as meningitis, then a lumbar puncture should be done. Exchanged blood transfusion has got very little evidence-based data on it, but it's not contraindicated. And in fact, it is done in patients with a very high, so greater than 30% parasitemia. One would consider and one would do exchange transfusion. What that involves is 2 cannulas, one side where blood is actually removed from the patient, whilst on the other side, blood is given to the patients. So what are the complications of malaria? And for the exams, the important ones are cerebral malaria, any altered state, and this might have seizures or it might be coma. Hypoglycemia, and again, this might be due to quinine or might be due to the parasite. Severe anemia, and this is especially so with falciparum malaria. Jaundice, and this will develop from hemolysis from the parasitized red cells. Thrombocytopenia, as the platelets are cleared with the erythrocytes by the spleen. An ARDS, or pulmonary leak syndrome, which is pulmonary edema, that can be a severe manifestation of malaria. Disseminated intravascular coagulation can present, as can hyperreactive malaria syndrome, previously known as tropical splenomegaly syndrome. Certainly now in the exams it's referred to as hyperreactive malarial syndrome. Black water fever can be a presentation of complicated malaria, as can glomerular nephritis, although this exclusively occurs with P. malaria, Plasmodium malaria infection. Let's look at other aspects in question 2 of malaria. Which of the following is true regarding falciparum malaria? Cerebral malaria is a rare cause of death. Dormant hepatic hypnozoites can cause symptoms 1 year later. Jaundice is usually due to liver failure. Parasitemia less than 10% is considered mild. Convulsions are pathognomonic of cerebral malaria. Please consider these and see which of these is true. So what you'll find is none of the answers are correct. Cerebral malaria is a very common cause of death, and falciparum malaria does not have a hypnozoite phase. Jaundice is not due to liver failure, it's due to hemolysis actually. Parasitemia less than 2% is considered mild. Anything above 2% is considered severe. And convulsions can occur with cerebral malaria or without it. Remember, febrile convulsions do not necessarily mean cerebral malaria. So then let's look at the hypnozoites and the relapsing phase of malaria. There are no relapses from falciparum malaria after successful treatment. The relapses can only occur with Vivax or Ovale. This is because they can lie dormant in a phase known as hypnozoites for many months, and this can relapse sometimes even years later. To clear the hypnozoites, you would need to use primaquine, and this clears Vivax and Ovale from the liver. Look closely at the caption, which shows you would need to use primaquine, and this clears Vivax and Ovale from the liver. Look closely at the caption, which shows the malaria life cycle. This is important for the exams. So starting from the mosquito, you will see that it will inject sporozoites into the humans. These will go to the liver, and not with falciparum, but with the others, there is a hypnozoite phase where they go to sleep, hence hypnosis. And then there's the merozoites, which might release gametes and go on to trophozoites, and the gametes are taken up by the mosquito, and it's in the mosquito that they will develop in the gut and go to the salivary glands. So that's in a sense the life cycle of malaria. And remember that the relapse is for the hypnozoites of Vivax and Ovale. So let's look at other aspects. So which of the following are true regarding malaria? Inadequate prophylaxis may lead to prolonged incubation period with P. falciparum malaria. Again, Plasmodium falciparum recurrence may be due to sporozoites in the liver. Immune complex-mediated glomerulonephritis is associated with recurrent Plasmodium vivax. Quinine is useful as a suppressive agent in chloroquine-resistant malaria. And finally, Plasmodium vivax commonly causes thrombocytopenia. Please consider these to see which is true. A and D are true. So inadequate prophylaxis will lead to a prolonged intubation. Essentially what we're saying is inadequate therapy will lead to suboptimal treatment of falciparum and should not be done. And also, quinine can be useful as a suppressive agent in chloroquine-resistant malaria. The problem with using it as a suppressive agent is that you increase the risk of black water fever, and therefore it's not the preferred method for suppressive agent. Looking at B, the reason that's wrong, it should be hypnozoites, not sporozoites. And looking at C, it's not Plasmodium vivax, it's Plasmodium malariae. And Plasmodium falciparum commonly causes thrombocytopenia in E. Another important aspect for the exams is what to take as prophylaxis, as suppressive therapy against malaria. There is a map there which will show you all the areas where malaria is highlighted, and therefore anyone traveling to those areas, largely Sub-Saharan Africa, Southeast Asia, and therefore anyone traveling to those areas, largely Sub-Saharan Africa, Southeast Asia, and the Indian subcontinent, should be taking malaria prophylaxis. Mefloquine, also known as Lariam, is taken once a week. That's important for the exams. The side effects in less than 1% are weird dreams. Ideally, it should not be given to children. Malarone is once a day. Doxycycline is once a day. Remember, the side effects are important in the exams: photosensitivity, rash, and also nausea and vomiting. Chloroquine and proguanil, especially in areas where there is no resistance. Bed nets as preventive therapy, as is long clothing during the evening, and DEET, which can be taken as a spray. So, let's look at which of the following are true with regard to malaria. Chloroquine and proguanil are recommended as prophylaxis in young children in areas of chloroquine resistance. Mefloquine is an appropriate drug of prophylaxis in a chloroquine-resistant area. Chloroquine can be used in children with epilepsy. Doxycycline is contraindicated during pregnancy. And finally, negative blood film excludes the diagnosis. Which of the following are true? Quite a few of them are. Surprisingly, chloroquine and proguanil are recommended as prophylaxis in young children in areas of chloroquine resistance. Again, because of the non-use of chloroquine in many areas for the last 10 years, there is some sensitivity to chloroquine. And because most of the other drugs, like mefloquine, are not recommended in children, chloroquine and proguanil is the recommendation. Mefloquine is what you would use as the appropriate drug prophylaxis in an area where there's chloroquine resistance in adults. Doxycycline is definitely contraindicated in pregnancy and also in young children, tetracyclines, because of coloring of the teeth. And certainly chloroquine cannot be used because it can induce or lower the threshold for seizures. You require 3 blood films before you can exclude the diagnosis. I hope that's been useful in covering malaria and infectious diseases, and good luck in the forthcoming exams.